once it's visible.
Thank you, sir. Thank you for introducing me. And we all know this story. Being in Tamil Nadu, we can't say that we don't know this story. So one is Dr. Muruga, who goes around the world, who takes time and then eventually accomplishes his goal. And the other is a smarter fellow, Dr. Vinayaga, who simply does a smart thing, did with a shorter span of time, and he achieves his goal. So eventually this topic is about that. So if you have an objective, how early you can achieve the objective in a smart way, in a shorter span of time. But even though that objective, even you achieve in a shorter span of time, it must be reliable. So the goal of a point of care investigation in pediatric ER, this will be the first few slides. And what is the basic point of care investigation that is required in a pediatric ER, and what is the extended supports? What are the challenges in implementing in pediatric ER, followed by some case scenarios of how it is going to be helpful. So a point of care investigation is an investigation performed outside the clinical laboratory at the bedside of the patient, and we have to get an immediate result. And this result should help us in simplifying the decision-making process. It should not complicate the decision-making process. Many a time we do CAR test coming dengue positive, as well as clinical features are looking like sepsis, we get confused. So that is why nowadays we are not doing a dengue CAR test. So the point of it's not like you have an investigation available. That investigation should be reliable enough to help you in simplifying the decision-making process on further management of the patient. And the investigation should be simple enough to be performed by a non-laboratory personnel. And end result is the point of care, patient satisfaction and improved outcome, operational efficiency, and cost savings in some cases. So when I went through how was pediatric emergencies managed at the time when I was born, meaning in 1986, probably, I got this article which was published in British Columbia in Canada. So I was astonished to see that based on the immediate support, the most important monitoring signs were pulse, respiratory rate, blood pressure, and GCS. So at that time, there was no pulse oximeter to say that saturation is an important sign. And most of the signs were like the signs that they used were purely clinical with no point of care support. And then management looks like any child with respiratory distress start on oxygen and follow these pulse, respiratory state, and GCS, insert oral airway, and you have to intubate early within 10 minutes of the seizure beginning. I don't think nowadays people are intubating within 10 minutes of seizure beginning, but that was how it was in 1986. I don't know, some of my seniors, like Dr. Annamalai sir, can enumerate whether this was true. So then slowly when I went into the history of point of care investigations, we found like the first thing, urinary test strips that we now also use was first identified in 1964 for glucose urea, and slowly the urinary test strips evolved for detecting nitrate and detecting leukocyte esterase as well as ketosis. Glucometers came in 1993. ECG and SpO2 came into pediatric emergency practice only from the PALS 1996 guidelines onwards. Then came the focused assessment using sonography for trauma, the fast ultrasound technique that came into adult practice in 1997, but still it is not overwhelmingly used in pediatric in all centers. Bedside EtCO2 came into the PALS recommendation in 1999. Arterial blood gas analyzer, there is a bedside iStat. It was introduced in the market in 2003 to 2006, but still not routinely in all the centers, and it is not in any guidelines. And the point of care echo and ultrasound, slowly people are learning echo and it is evolving. So these are the spectrum of point of care investigations that can be done at the bedside in the ER to obtain a result. And how are these investigations going to be useful in our practice? So when we see there are various reasons for point of care investigations, including operation, utility, sampling, result reporting, cost and analysis. And almost from rapid test kits, even thermometer they have included as a point of care device, benchtop analyzer, blood pressure monitor, blood glucose monitor, dipsticks, pulse oximeter, and portable ultrasonography, and malaria detection kit. So what is the role in ER? So in ER, our basic ideology is to identify what is the status or severity of physiologic decompensation. When you say respiratory failure or respiratory distress, what is the status? or cardiac, what is the status and why it happened, whether it is hypovolemic, cardiogenic. So that you need to know with the point of care investigation so that you can decide your management. Second is to identify reversible factors to correct this physiological decompensation. So these two form our goal of whatever point of care investigation that we identify and we plan to use in our ER so that we improve the patient outcome. And we all must remember that very seldom this point of care investigation is used in etiological diagnosis in ER. So what are the basic point of care devices required? First and foremost is pulse oximeter. Post COVID, I think everybody will be having a pulse oximeter or a finger pulse oximeter. It forms the basis. Probably 10 years before it was not available in everywhere, but now I think even individual homes they have a pulse oximeter. Next comes ECG. ECG as a monitor, as a separate instruments, many of them have as a monitor, which as a multi-para monitor is present in mostly in all of the ERs, but very seldom we attach ECG to most of these children. Mostly we monitor the pulse oximeter and the pulses waveform, but we don't always use ECG in all children. But the indication is always use ECG in a child who is unstable. So take at least one ECG reading for a child who is unstable. Next is glucometer. Glucometer has formed a part of pediatric triage and is being extensively used because glucose determines most of the physiological derangements in our body, and it is always it is mandatory in a pediatric ER to ensure that a sick child has a normal glucose level. And urinary dipstic test strips. So first I'm going to discuss about the ECG. So we all have to have a look into this ECG. This is the lead to ECG, which is very important. And when you attach the simple limb leads of an ECG monitor, when you see a lead to showing a P wave, a QRS complex, the S is small, R is prominent, and a normal T wave, the width of the QRS complex should not be more than 2 small boxes, and the QT interval should be normal, meaning when there is another R wave, that RR interval should be, the T wave should end just half 50% before the RR interval. So if this is there, your lead 2 is normal, then most of the condition you would be ruling out a cardiac pathology. But when you find there is an axis shift, meaning there is a deeper S wave or an equiphasic S wave in lead 2, it means there is definite axis shift both in the right as well as in your left axis or an extreme axis. There should not be a deep S wave in lead 2. If there is a deep S wave, then you have to think of an axis shift, which can probably be an underlying congenital heart disease missed for a long duration, or could be a dilated cardiomyopathy, which you are going to miss because of a significant axis shift. And second important thing is the ST and the T wave. ST segment should be isoelectric, like it should be at level with the PR segment, and T wave should be seen and it should not be more than half of the QRS complex. So these are the information grossly. You don't need to know everything about ECG, but these are the gross information you need to know just to identify whether your child is having a cardiac reason or a non-cardiac reason. So what other information can be obtained from ECG? Electrolyte disturbances, hyperkalemia and hypocalcemia, arrhythmias, wide and narrow complex tachycardias, bradyarrhythmias, electrical alternance, cardiac tamponade or massive pleural effusion. And if you find a low voltage QRS complex, mostly it is due to dilated cardiomyopathy or a pericardial effusion. Next comes the urinary dipstic test strips. Most of you would be having, and it is an essential point of care testing in an ER. And we widely use this to detect ketoacidosis. Like there are now keto strips available in several tertiary centers, but this is one of the commonest tests that we do in urine to detect the presence of ketones. So when you have a child whose blood sugar is high and you have a urine dipstick and you use that, if there is no ketones, at least you will be ruling out a diabetic ketoacidosis in a sick child with acidotic breathing. So you can identify diseases of kidneys and urinary tract. For example, if your specific gravity is too low in a child with acidosis and ketones are negative, you should think about a tubulointerstitial disease or a renal tubular acidosis. If you have glycosuria, a lot of reducing sugars in your urine and ketones positive, it is DKA. Sometimes very high icterus, which is not clinically palpable, can be seen as a urobilinogen excretion in the urine. Hemolytic disorders can show blood or hemoglobin in the urine. So these things can be detected. And in infants, especially with high-grade fever, if you have bedside urine dipstick At least if you do that, if the nitrate and leukocyte esterase is positive, you can say that these children, they are most likely to be having a UTI, and you can send a urine culture test before starting antibiotic in these children. The turnaround time for this test is at least is minimum 1 to 2 minutes. Therefore, even in OPD practice, you can use, and you will be able to identify most of these illness in the OPD practice also. So what are the advanced point of care investigation? I'm going to take some time on this slide because this is going to be widely available in most of the units in another 10 years, which is ultrasound. Now also it is available in almost all the tertiary units, but even it is going to penetrate in the districts levels also. So ultrasound, cardiac, lung and abdomen, blood gas analysis, serum electrolytes and hemoglobin. So most important and widely propagated bedside point of care, which is going to give additional physiological information about the patient's sickness, is your lung and cardiac ultrasound. Why this has been gaining popularity is because of its good sensitivity and specificity, even in a even in a trained emergency physician or a trained pediatrician hands. The sensitivity is around 96% with a specificity of 93%, which was observed in a meta-analysis. And mostly these in lung ultrasound, it is used to ruling out rather than ruling in. For example, if your lung ultrasound is normal, you will be ruling out a pneumothorax rather than you are going to rule in. If it is abnormal, you cannot say it is definite pneumothorax probably, but you can definitely rule out a pneumothorax or rule out a pleural effusion rather than you can completely rule in. Next comes your cardiac ultrasound. It has a good sensitivity and specificity, and it is around 95% and 88% with strong inter-observer agreement between a cardiologist and a emergency physician. So all it requires is a few months of training, and the things can be done. So what is our aim? We have to know what we have to look into cardiac ultrasound. We don't want to identify congenital heart diseases to the point like a pediatric cardiologist, but all we want to know is to assess the volume and to corroborate that with the clinical feature, to assess the cardiac contractility and to rule out a cardiac tamponade, because this is what we do in pediatric emergency. So place the probe at 12 o'clock position. The pointer should be pointing towards 12 o'clock. And measure the maximum. You will be able to see the IVC at this point. Measure the maximum diameter of the inspiratory phase and measure the diameter during after the IVC in the expiratory phase. And this is the distensibility index and the collapsibility index. And you interpret based on the distensibility index and the collapsibility index, or on an eyeball view. If you see, this is a normal IVC which is expanding during expiration and mildly contracting during inspiration. This is a volume depleted IVC where you can see the collapse is more than 50% just by an eyeball view. So this child will require fluids. And this is a distended IVC where you can see there is a not big difference between the inspiration and the expiration. So these are simple eyeball techniques where you can measure the IVC by an M mode and you can see the respirophasic variation. Next, you are worried about the contractility. So this is the place where you are going to place the probe. It is towards the right shoulder. This is called as parasternal long axis view. You can see the heart like this. This is the left atrium, left ventricle. This is the aorta where the blood flows out through the aortic vein. So this is the left ventricle. You are going to see what is the ejection fraction, the contractility of the left ventricle. So you are going to use an M mode and cut the heart at the level of papillary muscles. Once you use an M mode, you will get a view like this. So there is a diastolic level and there is a systolic contraction. So this is systole, this is diastole. So measure the diastolic diameter and the systolic diameter. You feed into the system, you will get the ejection fraction. A normal ejection fraction is more than 50. Anything less than 50 indicates a poor contractility, and any ejection fraction more than 75% indicates that there is a hyperdynamic cardiac contractility. So for example, this just by seeing you can see that the heart is contracting poorly. This is the left ventricle, which you see is not at all pumping. So these two things are very important. And the third thing that you are going to look into is a pericardial effusion, which is you can see a hypoechogenic gap between the left ventricle wall and the liver. So when there is a hypoechogenic gap, which means that there is a pericardial effusion. So these are the three things we can easily identify for a cardiac ultrasound, which can help in our management in an ER. Next comes the lung ultrasound. As I mentioned on the right side of this slide, the lung ultrasound, the sensitivity and specificity almost for all condition is more than 90%, except for an occult pneumothorax. That is why most of these ultrasounds are used to rule out rather than rule in. If lung ultrasound is normal, you cannot say it is the pneumothorax is not there, but you can say like, okay, the at present the pneumothorax is not significant enough in a pediatric emergency condition. So these are the places where you will be placing the probe from the nipple line, anterior axillary line and the posterior axillary line. Similarly, on the back side, it is the suprascapular and the infrascapular region. So those are the 6 places where you will be placing the ultrasound probe, which will be like this in the sagittal plane in a cephalocaudal direction. So there are 2 lines that you have to remember. It's so simple. One is called as the A line, which is reflected from the air. So these lines, these prominent lines which you are seeing in this left side is the A line. If A lines are there, then the lung is then it is not an abnormal lung. A lines should be there in a normal lung. Absence of A lines, if you see no A lines in the lung ultrasound, then you can say that the lung is abnormal. Next comes the B lines. B lines is those lines which is reflected by fluid in the lungs. So what is the B lines? These are these comatile artifacts which erases the A lines. If you see these lines, then probably there is fluid in the lungs. And if there is a pneumothorax, when you do an M mode, you should actually see something called as a seashore sign, which will be like grains of sand. But instead of this, on an M mode, if you see a barcode like sign, if you put an M mode, you see sign like this, then definitely there is a pneumothorax on that segment. So pleural effusion, we all know, we have seen radiologists checking for pleural effusion. So as soon as you place the probe near the diaphragm, what you'll be seeing is an hypoechogenic area, just like in the quadrangle. If you put an M mode, you will see something like wave which goes on as the lung is moving. So if this is there, then there is a pleural effusion. Abdominal USG, mostly emergency physicians or pediatricians, we don't encourage doing in ultrasound in pediatric ER, because it is found that the fast is not reliable in children. Most of the injuries in children, the blunt trauma in children, they do not show free fluid. A CT would be a more appropriate tool to identify blunt trauma rather than a fast ultrasound. Next comes the point of care blood gas, electrolytes and hemoglobin. As we see, acidosis, electrolyte imbalance, lactate and IANA, these are used in many tertiary and quaternary centers. The problem to use in smaller setup is they might not be cost effective because the machine expense is high, it's 2.5 lakhs. And also the cartridge also is quite expensive, and these things can be weighted in emergency. Whereas in high volume centers, you have to prioritize ward or ICU care. You have to identify if there is a transplant patient you need to do for an immediate management. Therefore, in high volume and tertiary and quaternary centers, these point of care blood gas are recently being used and it is evolving. So what are the barriers? There are different barriers both in patient's perspective, doctor's perspective and administrative perspective. So patient perspective, it's due to poor financial condition, unwillingness for, these are the thoughts that they will think like as soon as a doctor comes, immediately a pediatrician does an ultrasound, does an echo, they will feel like they will be charged for each and everything within half an hour. So this is the patient perspective of thinking. Coming to the doctor's perspective, the confidence, the drawback of the POC devices, the poor association between the patient and the doctors, the patient burden, and no support in handling facilities. You have an ultrasound, you know to do, but you don't have a support team or a cardiologist or some other backup to ensure that what you have done is normal. So these are the problems in peripheral levels to increase on the point of care devices or the utility in emergencies. And administrative perspective, obviously the financial management comes into place and the workforce management comes into place. So how to optimize? Identify the need of your ER based on the profile of your patient and the support system you have around you. The basic point of care facilities which I had discussed should be made available in all emergency rooms. Point of care ultrasound for lung and heart, it has a good facility when you get trained and you keep on practicing. Blood gas, electrolytes and hemoglobin, the role in high volume volume ER and in quaternary care is there, but it is not that much in peripheral or in secondary levels. So coming to this case example, like what you can do with basic POC care. So you get a 15-year-old child with developmental delay, vomiting and decreased oral intake for 1 day. The child goes to a hospital where the child was found to be having hypotensive shock. And as usual, the child was given bolus and it was referred. So if you would have attached the child to a monitor, you would have got a lot of information. So what is seen in this monitor? What you can see is you can see the QT interval is so prolonged, and you can see the pulse oximeter showing a alternance. So what does this mean? The QT interval is so prolonged. So when you see the ECG, you have to suspect that the QT is prolonged. Probably this child either has a long QT kind of a syndrome, but more commonly, what could it be? It could be a ionized hypocalcemia, which is treatable and reversible. So once we did an ultrasound, we found that there is a lot of B lines because there is fluid in the lungs, and the IVC is distended. Ejection fraction was only 20%, and the point of care ionized calcium was showing 0.48. And we immediately started ionized calcium, and post calcium, you can see that the QT interval in the previous ECG has normalized, and rhythm is slowly coming to the normalcy. And blood pressure also improved. So without fluid, without maximum inotropes, just by correcting calcium, this child achieved normal blood pressure, normal perfusion, and normal ECG. Then coming to this child was in the COVID ward of Institute of Child Health. Child was having breathing difficulty.
You are not audible now.
I think his power went.
Seems to be there's some issue with the connectivity, sir.